Okay, welcome to the World Heart Federation Heart Cafe. My name is Pablo Perel. I'm the Senior Science Advisor of the World Heart Federation. I'm professor at the London School of Hygiene and Tropical Medicine. And we're here today with an amazing panel at ESC to talk about global cardiovascular data. I think I don't need to convince anyone about the importance of data, but of course, there are many challenges, and we're going to be discussing with this amazing panel. So let me do a brief introduction. We have first Greg Roth, who is professor of medicine at the Division of Cardiology at the University of Washington, and he's leading the work on cardiovascular disease for the global burden of disease at IHME. We have Mark Miller, who is reader at the Center for Cardiovascular Science at the University of Edinburgh. He's a chair of the Air Pollution and Climate Change Expert Group from the World Heart Federation, and he led the recent report of the World Heart Federation on cardiovascular disease and air pollution. To my right, we have Chiara Di Cesare, professor of population studies at the University of Essex, and she's leading the World Heart Federation Observatory. And finally, we have v02, who is a research fellow on health analytics and machine learning, working on the NCD risk factor collaboration at Imperial College. So, as you can see, we have an amazing panel, and we're going to have an informal conversation about the different initiatives that you're leading and some of the challenges and also way forward. I would like to structure the conversation about three main topics. One that is obtaining the data and analyzing the data. One that is about using that in terms of different audiences, policies, research priorities. And then the final topic, moving forward, innovation and how you see the different initiatives into the future. So I'm sure everyone is well aware about the different initiatives, but maybe to start, I will ask you, Greg, and Bin, to summarize what is, in your case, GBD, and you NCD risk factor collaboration. What do you do? So, Greg, over to you.
Yeah, thank you very much for the opportunity to join this panel. The Global Burden of Disease study is an ongoing effort to bring together all of the data on health in the world, and then using a range of statistical methods, create robust estimates of what we call disease burden. And that can mean a number of different things, death rates, prevalence of disease rates, but also summary measures like healthy life expectancy and disability adjusted life years. And we do that for every country in the world, and we do time trends for every country in the world. The goal is to produce an evidence base to inform public health and policy decisions so that we can move from a world where decisions are made for a whole range of different reasons to a world where public health is really based on science.
Okay, and we're going to dig into some of those issues. How many years does GBD have?
Yeah, so the Global Burden of Disease study starts in the 1950s for deaths and moves all the way to the present day. It starts in 1990 for prevalence and risk factors, and now it actually moves into the future as well and projects all of these trends to 2050.
Okay, excellent. So, Bin, would you tell us about the NCD risk factor collaboration, what it is and what you do?
Thank you for the opportunity to be here. NCD risk factor collaboration is a global network of scientists who have collected population representative data on key non-clinical disease risk factors, including obesity, hypertension, diabetes, and so on. So the main purpose of this collaboration is to leverage the global data on these NCD risk factors to understand the patterns of their occurrence and in different populations, and to understand their burdens and the change over time as well. And the results of our work is highly used in the scientific literature, as well as by the World Health Organization as the official national estimates for these risk factors for different countries. So we are increasingly look at complex scientific questions that can be answered with these kind of data sets to look at the patterns of different disease, the co-occurrence of different diseases as well as risk factors, and how they are changing both historically and more recently, so that we have a perspective how these risk factors will evolve into the future. And these are very important informations that the policymakers can use to inform the formation of health policies for their countries to improve the health of their respective population.
We'll come back to that and how the information is used. But maybe you also want Chiara to say something about the World Heart Observatory. What is it? And
yeah, absolutely. And thank you for inviting and to this amazing panel. So the World Heart Federation, what we are trying to do is that thanks to these amazing initiatives, we try to bring data from global burden of disease, NCD risk, other global initiatives, and also multi-country studies in one place for an audience that is, a variety of audience. So from policymakers to cardiologists and we just focus what we bring within the World Heart Observatory. We just focus on cardiovascular diseases. So outcomes, risk factors, policy, for example, we bring a lot of the data from the World Health Organization on policy and health system. So we try to have one single hub, one single entry for all these different initiatives. And we hope that brings more use of the data, and of course, more use of the data from GBD and CD risk and other initiatives. So it's one place to go for data on cardiovascular diseases.
Yeah, and I hope it's known by everyone by now, but if you haven't seen it, I think it's good to use it and provide feedback, because we keep improving. And one of the outputs of the World Health Observatory is the annual report. So you led the report this year. So can you tell a little bit about the report? I mean, what was and the audience and impact it had?
Absolutely. And of course, first of all, thank you for the invitation to be here today, to invite a humble physiologist into the big world of data. So the World Heart Report this year was looking at air pollution and cardiovascular disease, but it wanted to incorporate all the different angles. But obviously the data and the burden of disease caused by air pollution was one of the biggest things. That's what gets the headline figures that draws people attention. That's where we really get to understand just how much of a problem air pollution is for cardiovascular disease. And despite working in this field for 20 years, it's that level of attention that we need. And so we can, with the data that we used, and we used the WHO data from 2019, we were able to come up with the statistics that did get that attention. For example, that one particular air pollutant is associated with 2 million early deaths from ischemic heart disease and almost 1 million from stroke. These are important figures to do, but also allows you to sort of dig into the data. And the data was really important looking at global trends. So we can have situations where air pollution is improving across the world, but we get a much better idea of just how much that improvement is, and it's rather slow. But most importantly, what's the effects on health and what the effects on the key heart conditions as well.
And it had part of the work of WHF is increase awareness and policy. I mean, it had a huge impact in terms of media, and the report was really well received, and I think increased awareness of this topic. It was a really important report. So getting into more into some of on the first topic, that is obtaining the data, and I know probably particularly you, Greg, and Vin, you can spend the 3 days talking about this. It's very challenging, but sometimes we get only the data from GBD, but there's so much work behind that. And it's so maybe you can tell us a little bit about that machine. How does it work? To give us an example, and in particular, then maybe I'll ask you to tell us, where do you see that there are still important gaps?
There are tens of thousands of individual data sources that feed into the estimates from the Global Burden of Disease study. And one thing people might be interested to look at is the Global Health Data Exchange. This is a publicly available, easily searchable database of every single input that goes into the study. Transparent, And you can go right there, and if the data itself is publicly available, it can be downloaded. There are links to take you to the source, whether it's from a government or an academic organization or some other source. And so we really make it very easy to see what those inputs are that drive the estimates. Having said that, there are huge gaps in what we know. And I like to say that the global burden of disease study is both a way to understand what we know about health in the world. It's equally useful for figuring out what we don't know about health. And those gaps are actually part of the message. And the global burden of disease study is one way that governments try and figure out where to invest their limited resources for surveillance. And we provide information on where the gaps are largest. Because the global burden of disease study is an iterative analysis in which we repeat the entire analysis every year, we often can help add our voice to driving investments in surveillance. Without that surveillance, we're blind. One thing that people might not be as familiar with are the challenges in countries to actually collecting that primary surveillance data. And I'll just make one quick comment about that, which is that one area where things are evolving rapidly are the regulatory environments within countries that have previously not had legislation around the management of data. So this is something that's changing very quickly. There's lots of advances being made, in particular in sub-Saharan Africa, where governments are beginning to create the legal structure that allows data to be collected, allows the privacy of that data to be maintained, and most importantly, creates a way for that data then to be shared in a safe way that can help people make decisions while simultaneously protecting the privacy of the citizens and patients who contributed to the data sets. So I think that regulatory environment is changing very quickly, and that's actually something that we're really heartened to see.
Can you give an example of, I mean, you mentioned sub-Saharan Africa, maybe a region, I guess, or a condition where it's particularly challenging, and you say, here we have a really important gap that needs to be improved?
Yeah, I mean, in particular, I think it is very challenging to find information on the prevalence of coronary artery disease. We know that coronary artery disease carries immense risk for people who have that condition. We know it's incredibly common, but we also know that there's huge variation between different locations and countries because the risk factor profiles in different countries vary. And in fact, even in places where exposure to risks are similar, we see variation in coronary artery disease, probably because of exposures during the life course that we don't yet fully understand. You know, traditionally, there have been studies that have and surveys that have asked people if they have coronary disease, but if there's no healthcare, you're not going to know that you have coronary disease. There are studies that have used EKGs, but our ability to use traditional methods to interpret EKGs is quite limited. We rely on things like the presence or absence of pathologic Q waves. I'm very excited about machine learning in this space. I think it offers some real opportunities to use a traditional test like an EKG, but really boost it into the future and get much higher quality information on who has atherosclerosis in their coronaries, and then who has so much atherosclerosis in their coronaries that they have obstructive disease and are at high risk for events or they're experiencing angina.
So we'll come back to that at the end, and I'm very excited also as well on the use of AI, and particularly on ECG, I think is amazing. But what would you say to people that say, well, the problem with GBD is that it gives you, in a way, the illusion that there is data. In some places, there is no data. Yeah. And that doesn't allow people to collect new data. I mean, what do you answer to that? That's something I'm sure you hear.
Yeah, I mean, you know, what we hear from the people who both contribute to the study, and there are over 10,000 collaborators around the world in every country in the world who are engaged in the study. And what we also hear from governments and decision makers is that that is just not true. What we hear is that the GBD, in fact, drives new surveillance investments because it helps quantify the availability of information in a way that previously was very fragmented and didn't exist. And the other issue, of course, is that decision makers have to make a decision today. And so they need something to help guide those decisions. They can't wait into the future. Those decisions are either going to be made with the best available evidence today or no evidence today. And so the global burden of disease in many countries is often the best available evidence today.
And as you said, I mean, the gaps is there if you look at that. I mean, you know, which is the primary data. That's something initiatives like the observatory can help identify and also highlight. But moving to the NC risk factor collaboration. So tell us what is kind of your process and as I said to Greg, the kind of machine behind the output. So can you share a little bit of that?
Yes, of course. I think it is the same with all the global collaborations. I think Greg mentioned part of it, but there's a process that precedes all the data analysis and standardizing and data like dissemination of the results to the world, which is data access. It is very, very challenging to do at a global scale. To start with, there's sea of information, but not all of them is usable for this kind of global surveillance, global collaboration on this surveillance of these risk factors. So there needs to be a systematic assessment of the eligibility of the tens of thousands, even hundreds of thousands studies that's conducted that have collected some information of these risk factors across different populations. We need to make sure they all meet some minimum criterion to be included in this effort, so that low quality data do not add noise into this work. So and then on top of, at the same time, which is a dilemma, at the same time there's scarcity of data in many parts of the world where just simply not enough data have been collected. This applies to regions of many countries in the African region, unfortunately, as well as in Central and Eastern Europe and in Central Asia and other parts of Asia as well. So these countries, they have maybe one or two surveys of these important cardiovascular risk factors, but then and then that's it. Then you don't know about like how they are changing over time because you just have data on one time point, for example. Or they only have measured people aged between, say, 15 and 49 years of age. You don't know what's happening in the younger ages. You don't know what's happening in the older ages, which are both very important life stages of life. So there's both a overwhelming number of studies to pick out the useful information. At the same time, there's a scarcity of information in places or in the populations that these information are very urgently needed.
You look mainly in cardiometabolic risk factors. That's your focus. And is the criteria to be representative from the population, or what's the criteria in terms of the sampling of the studies that you have?
It depends really on the purpose of the surveillance. I think for the NCD risk factor collaboration, our criteria is that the study needs to be representative of the general population. So it's not the healthy population, if you like, of a nation, or the people with certain disease of a nation. It needs to cover the entirety of the population in a representative way. So then when it comes to specific studies, there are a lot of subtleties that you need to look into and decide whether they are representative of the country that they are trying to represent. So yeah, that's.
And is there any specific risk factor, the one that you cover, that is, you would say this is the most challenging one to get data because of different definitions? Or
probably diabetes is the most difficult one of the ones that we have covered. So to start with, you could define diabetes based on many blood biomarkers like fasting glucose or HbA1c or random glucose. It varies a lot from study to study. How to standardize that? What you accept, what you don't accept, and then at the same time, a lot of studies could have very different protocols in terms of who are measured of what. So you could have a survey that attempts to measure diabetes prevalence in a population, but the way they do it is that they did not measure, for example, OGTT among those who had already reported a diagnosis of diabetes, which makes sense for the patients. But then how do you incorporate these data into this global surveillance efforts is a huge challenge. So there are that's just an example of the differences in how studies are conducted across different populations. There are all kinds of variations for all these risk factor and diseases that you can think of, from the tens of thousands studies that ours and GBD put together. So these are real challenges: how you get access to these data, how you deal with the variations in how they are conducted, how data are collected, and how then you synthesize all this information to produce what is the best evidence given the information that's available to us, so that policymakers can use to make decisions today. That's very important.
So we'll come again to the use of that, but just to finish with data collection and challenges, maybe on air pollution in particular, what are the, if you can say, of course, again, you can spend a lot of time about limitations, but can you highlight a few that you say these are the key limitations we have today in terms of air pollution?
Yeah,
we have to focus on a few.
Absolutely. Although I'm going to give you quite a few, I think. So, I mean, essentially, when you're looking at air pollution and health, you're looking for three things. You need your air pollution data, you need your health data, such as your cardiovascular indices, and you need data on the confounders to adjust or stratify for those. But I think your question is probably relating to the availability of air pollution data itself. And this probably picks up on many of the themes I think the rest of the panelists have discussed here. And I could perhaps give you examples from 4 different locations. So we can pick, for example, where the ESC is in itself, where we have London, where we have amazing air pollution data. Now, the predominant source of air pollution data is from government stationary monitoring data. These are very expensive, very reliable pieces of equipment that will provide continuous measurements of the key air pollutants throughout. And London is a huge network of this. It also has a big active research in air pollution, and it has research monitors, which are at a scale now where they integrate together to provide a really big holistic view, almost on street level, where you can know that if someone lives at this address, this is their residential exposure to air pollution. But then we can look at a second location, and I'm going to choose my own home location in Scotland, in Edinburgh. And again, in the UK, we have a good sources of air pollution data from these monitors. But Scotland is a very small country, and Edinburgh is a very small city. But we have a good measurement of some of the key air pollutants, which are particulate matter. So we have about 10 different particulate matters around the city. But there's one source of particulate matter, the very small one called PM2.5. That's the key one for health. Yet there are only 3 PM2.5 monitors in Edinburgh city centre. And you can live, and if you were doing a classical epidemiological study without the modelling to fill in those gaps, somebody who lived right on the coast in Edinburgh could have exactly the same exposure as someone who's right in the city centre. Then my third location would be something like, let's say, some of the East Asian megacities, where again we have wonderful monitoring, but it's the availability of the data that is the problem. And this has improved a lot over recent years, but actually just accessing the data and allowing researchers to access the data has been difficult. It's been challenging. There have been barriers in place, and some of these are understandable because there's gaps in the data. The data needs to be cleaned, and that needs to be done responsibly. But even just accessing some of that data has been challenging. And then the last one is coming back to Greg's point, would be something like sub-Saharan Africa, where we have a huge continent and there are only 7 countries that measure air pollution with stationary monitors. And within those, there would be maybe, I think, 2 that measure PM2.5. And yes, we have ways around this to tackle this with satellite data to fill in the gaps, with modeling, but they come with all these assumptions that we're talking about. So that's really the sort of scale of the challenges there. But of course, we can tap into all the experience we know from the data science and the work that the World Health Organization does, that GBD does as well, to try and tackle those limitations. And actually, we can now get quite good burden scores, even though there's a good deal of uncertainty about some of the actual air pollutant data.
Okay. So even with all these challenges that you face, of course, we have some, I mean, good and estimates and global initiatives, and then to move to the next thing is how we use, how it is used, and how it can be used. And maybe I want to go back to you, Chiara, and because I think the observatory maybe and WHF is interested in the use at the policy level. And also you have experience with other global reports that you were involved. You can tell a little bit about that, and also how you see the use of global data to inform policy.
Yeah.
Examples and challenges as well.
Yeah, so going to the other initiative I was involved, so the Global Nutrition Report, and it's like, again, it's like a hub of the best, most up-to-date data on nutrition in the world. And this has also mechanisms within the Global Nutrition Report for accountability. So what is the Global Nutrition Report? Is the official accountability framework for any commitments that countries, stakeholders make in terms of nutrition. So whenever there is a big event, a big summit, and government stakeholders go and bid for funding for fighting, for example, malnutrition, the Global Nutrition Report helps those stakeholders to follow the commitments they have made. So I think that I use the word accountability and monitoring in a very good way. I mean, accountability is not to make, it's just to understand where we are going with the investment and the resources that we have. So for me, all these global initiatives are extremely important, and go back to what GBD and CD and do is that they allow us to understand, are we doing right? Are we moving in the right direction? And this is when Greg was saying, policymakers can use that information to also understand where we are going. So for me, is the evidence that allow us to then make the investment in the right direction. The observatory, and going back to a bit of the discussion that has been done so far, is that allow people that are also, Greg and Bean have discussed GBD and density risk, and there is a technicalities behind, right? I mean, we want to make this more accessible to everyone, regardless of the level of, knowledge of the technical aspects of the methodology, the data, the problems that Bean and Greg were presenting before. So hopefully the observatory makes also this data more accessible and hopefully, understandable to a wider community. And policymakers is one of that community. So I think that's data are essential if we want to really know where we are going with what we are doing.
So it's interesting because I think we are all more kind of data driven and quantitative, but we want this to impact on policymakers. And you mentioned, I mean, this is an explicit aim of GBD. Do you work with policy scientists? I mean, because we speak the same language. But I think when you're trying to reach policymakers, of course, you need to understand how to present data. I mean, how GBD approach this issue?
Yeah, I mean, I would say that from the very beginning of the Global Burden of Disease study almost 30 years ago, that goal of creating evidence that is readily and easily available to policymakers has been really at the heart of the study. We do this in a number of ways, more than I can talk about right now, but I'll just flag a couple ones that I think are notable and important. One of them is not only are we publishing in academic journals, but we are creating infographics and one-page summary sheets. In fact, you can go to our website and select any country in the world and get a simple one-page, graphic forward kind of explanation of the burden of cardiovascular disease and risk factors for that country. That's really important. We know that policymakers don't have the time to always work through complex academic analyses, and they need that, summary quickly and digestibly, both for themselves and also their constituents, and they need it from a trusted source. And so GBD can offer that to them. But we also work directly with legislators around the world to try and produce the kind of evidence that they need for the specific question that they're grappling with. And I'll just give you one example of that, which is that recently legislators in Nepal were working to increase the taxation on tobacco products in Nepal. And we worked with them to create forecasts into the future using the existing time series of data on tobacco use and cardiovascular disease in Nepal to basically show different scenarios. And this is really important in the policy world. People need to see options because policymaking is complex, and it's usually not about choosing the very best policy. It's about the art of the possible, right? And so we were able to create a range of scenarios showing how different levels of taxation would affect life expectancy, which is a really important overall summary measure of health, as well as cardiovascular disease and cancers for the next 30 years. By injecting that kind of evidence into the debate, they were able to bring that to the Ministry of Finance as well as the Ministry of Health. And a lot of this work is cross-sectoral and has to go well beyond just healthcare. And that was a way of bringing evidence from the global burden of disease study into the real world.
And so you formally work with policy scientists from University of Washington that inform these different approaches.
So we have policy scientists at IHME, and we also collaborate with policy scientists around the world at other academic institutions and also NGOs. And so we work with policy scientists who are not in the academic space, but are in the non-governmental space, including at WHO, but also at lots of local organizations. In the example that I just gave, we worked with policy groups in Nepal, and really that's the benefit of our large collaborator network, is that we're really working very closely with people who are in that country and can bring their perspective and really make sure that the science and the evidence aligns with the problems they're facing.
Do you have a formal way of monitoring policy impact at GBD? I mean, like, I'm sure you have the impact factor of your papers, but I mean, because it's
so we have a global engagement team of both researchers and staff who are continuously working with our collaborators in every country to make sure that we understand what the impact of GBD is locally.
Okay. So moving now into the future, and of course, I mean, you're free to ask questions if any of you have any question but what are the innovations that you are already implementing, maybe from how you used to do the work and into the future? And if I can ask you how you see, I mean, particularly thinking, I'm asking you the use of machine learning and AI in the NC risk factor collaboration, and also if you can say, how do you see or how can you imagine the NC risk factor collaboration in 5 or 10 years?
It's a great question. I see innovations in 2 dimensions, not only on methodology. I'll come to that. I think the first innovation that needs to happen really is on data. So the reliance on the traditional population surveillance is not really the way into the future. We need to find ways to incorporate these routinely collected health data in health systems and other like digital forms of health data, incorporate them into this kind of population-wide health research. There needs to be innovations in terms of the data sharing mechanisms, the safeguarding protocols, as well as like what kind of like research questions can be answered by this kind of global data, and then we also need methods. So in terms of the innovations or methodology of the data that we're currently using, we are trying to extract more complex description of the health status of the population from this data beyond just simple descriptions of the disease, the prevalence of diabetes, for example, but rather how, say, obesity and diabetes, they are interacting, what kind of people gets, obesity but not diabetes, what can we learn from this concordance and discordance in the occurrence of disease from different individuals, what can we learn from their variations across populations. One of the key strengths of this kind of global collaboration is that we have the maximum amount of variation possible across different populations. From there, we can learn a lot of interesting stuff that can be.
Are you doing now anything kind of?
We can, yeah. We are. An example of the analysis we are working on is to try to use unsupervised machine learning methods to extract the clusters or phenotypes of individuals across different countries in terms of their cardiovascular risk profiles. So say, different countries may have high, some country may have a lot of people with high blood pressure at the same time together with obesity, whereas the other countries may have a lot more people who have normal body weight, but then at the same time high blood pressure. How frequent these different phenotypes, so to speak, appear in different populations, what's behind this like difference in the occurrence of these clusters, and how these we are using these techniques that can help us to extract information from the vast amount of data we currently have, and then to learn new things from them. I think there are key challenges, like how can you make sure that these kind of phenotypes and clusters learned from the data from different populations, they are comparable. They are apples and apples. You're not looking at apples and oranges from, say, US and India, for example. How you can make then useful conclusions from these evidence that's relevant for policymakers. All these are challenges that we are trying to solve with the data that we have and the advanced analytical methods that's available.
So you're already using some machine learning for this clustering of multiple risk factors. And I think yesterday we had a hard cafe about, we call it multimorbidity, although there is like a push to call it multiple long-term conditions as a term. And I think that's definitely something that moving to the future, I'm sure, well, you're already, and I think you presented in one of events looking at multimorbidity is one of the challenges. But going to the future, and I mean, Greg, you mentioned a few things already at the beginning. Tell me, I mean, get me excited about what you're planning to do with AI and ECG or other things.
Yeah, I mean, I think machine learning, neural networks, large language models, everything under that umbrella that we call AI is incredibly important for this kind of data-driven global health work that we do. We're exploring many different applications of this sort of range of new technologies. Many of them are similar to the things we've already heard about. We are trying to improve the efficiency of extracting data from sources into our databases. We're trying to improve our ability to know what science is actually happening in the world and to make sense of the absolute fire hose of research studies that are coming out every day so that we can be on the cutting edge and making sense of that. We're trying to move beyond the human networks that have previously informed our understanding of the science to making sure that we truly have objective, comprehensive, view of where research is and what kind of data is actually being collected. This is particularly important because the very nature of the data that we collect to track health is evolving. And I'll give one example, which is that even beyond things like ECG, because I've talked about coronary artery disease, CT coronary angiography turns out to be an incredibly important modality for actually visualizing, for seeing coronary atherosclerosis, which may in fact be the most common disease in the world. Not everybody goes on to have a heart attack or heart failure from it, but it's almost, in some countries, the entire population that's afflicted by it eventually. And it is, of course, the outcome of things like obesity and diabetes, but also genetic risk factors that we don't fully understand. Traditionally, this was a test that was used quite selectively for people who are having chest pain, for example. But increasingly, because it can now be done at very low radiation doses and the cost is going down and the availability of these machines are more common, we are starting to see population-based coronary CT studies in which we actually can understand not just how common coronary artery disease is, but how severe it is in the subclinical population, people who've not yet been identified. And so that's a place where, you could have a whole team of people just trying to read all the studies all the time. But we're starting to implement machine learning and AI tools to make sure that we're aware of where these studies are being done and that we can have that extra ability to see the data as it's coming through in real time.
On top of analyzing the data and getting, but what about, I mean, these days we have, I mean, all of us, we have wearable, we have data, and it will keep increasing, like even with your iPhone, and you have data on how many steps we have been doing here at ESC. I mean, do you see in the future you're going to start incorporating that kind of data?
The long discussion about wearables and personalized data. I mean, a couple of things there. That data so far, I don't think is as useful as people think it is. I think the condition where it is most important is probably atrial fibrillation. Atrial fibrillation is very common, and our traditional research methods for trying to surveil how many people have it are not adequate. Of course, a lot of these devices you're talking about are in the private sector, are commercial devices that people purchase, and companies are very protective of that data appropriately. And so there's that balance again of how do we collect health information from the population so that we can make better population level decisions, while at the same time making sure that we're protecting privacy, and that when we aggregate data, it's done in a way that's transparent and doesn't cause more problems. So I think that wearables are an important research tool, but the kind of wearables that we've all got, or the phones that we're carrying around with us, I don't think those are yet like the window to better population health.
Anything that if you have to dream on air pollution, and again, 5 years, 10 years from now, and anything that you've seen, you heard, that you think, oh, that could be a really exciting and innovative way forward of capturing any data of that?
There was a couple of things I'd mention. I'd say one of them is here and now, and maybe not wearables, but I think low-cost sensors. So we're talking about innovation, but innovation doesn't have to be extremely expensive technology. We're now in an age where we have low-cost sensors for air pollution, which can be mounted, for example, outside someone's home. And these can be, £100, $100 US. And these can make a big difference. So if we look at the African setting, now, we have a great understanding now of the burden of, let's say, heart disease in Africa that's related to air pollution. But if you really want to understand that, it's going to be very different if you can actually measure air pollution at its location. So in African settings, we have problems not just with outdoor air pollution, but with indoor air pollution. And you can make estimates of a household's exposure to outdoor air pollution with these standard techniques. But if you have a low-cost monitor, you can put one outside the house, inside the house, potentially a wearable for someone in their daily activities. And no longer will you be assigning a married couples where they will have exactly the same exposure to air pollution, where really traditionally the female role would be inside, exposed to high levels of, let's say, smoke from cooking and heating. And where outside it might be, for example, from vehicle exhaust if they're a driver. And although they're both exposed to particles, they're exposed to very different things. And actually, probably the cardiovascular consequences are very different. So being able to have that resolution with what is essentially quite a cheap tool, and to be able to do it in real time, is powerful.
And you said this is already available and happening.
This is happening, and I think it needs to happen more in low and middle income country settings. It's happening certainly now in high income settings, and we need more of it. And we will see that over the next few years. I think thinking to the future as well, the next thing would be to stop thinking of air pollution as just one thing. It's hundreds of thousands of different chemicals. And I mentioned one, this PM 2.5, which just measures particles in the air, but it measures them by weighing them. Now, that doesn't tell you anything about what that particle is made up of. It doesn't, for example, let's say if we look at vehicle exhaust, is it gases? Is it particles? Is it from the exhaust? Is it from the tires, from the brakes? These things are made of totally different substances, and without fail, some of them will have bigger effects on the lung, some of them on the heart, and they'll do it through different pathways. If we can have new technology where we can actually start to look not just at the amount of these particles, but actually what they're made of, then we can really actually start changing things with what interventions we do. Because it's going to be very expensive to try and reduce air pollutant to WHO levels. But if we can say, no, this is the air pollutant and this is the constituents we need to reduce, then this actually might be cost effective, and governments can put their money in there so they have the biggest health benefits.
I mean, I guess if we all dream, we would like to have definitely more spread on the data and more depth as well for almost any condition that we look at. I think I would like to give the opportunity if anyone has any question from the audience, or if you want to ask yourself any question.
I think, for me, just one comment, because I think so we talk about wearable innovation, and I think that what is still missing is that innovation is not equally distributed across the the world and within countries. So the wearable, I completely agree with Greg. And the other problem of the wearable is that it's not accessible to everyone. So even if the data would be of some use, are just selected on a specific subgroup of the population. So for me, in fact, using data from some of this innovation may in fact increase inequalities in whatever action or assumption we are taking. So for me, it's also thinking about access to innovation that needs to be equally distributed. At that point, maybe we are in a better place. And maybe by then, we will also have better innovation and technology available. So for me, it's a very important point.
Yeah, so in the most recent version of the Global Burden of Disease study released just this year, we actually identify conditions and risks that really are increasing rapidly and are the global health threats that we need to be concerned about. These include cardiometabolic disease, diabetes and obesity in particular, dementia, and other cognitive changes that occur related to the aging of the world's population, and infectious disease threats, including the possibility of additional viral threats and new pandemics. These are all things that we have to be concerned about. The last one I'll mention is temperature change related to climate change, but also related to other things like urbanization and the way urban areas develop, and migration patterns. So we're obviously seeing large-scale migration in many parts of the world, and human patterns of migration have major impacts on health that we really do not fully understand. And in particular, the implications for chronic disease and cardiovascular disease in particular are likely quite profound, especially because cardiovascular disease is unbelievably treatable, but access to that care is unbelievably limited.
So maybe just, you mentioned when was the last publication of GBD and what are the next steps? Maybe you can share that.
So the Global Burden of Disease study is currently coming out every year. The most recent version was released this summer. There are a series of high-level publications describing it published in The Lancet in May of this year, 2023, and we will expect the next set of results coming out next year.
And I don't know, from the NC Risk Factor collaboration, anything that is coming or that you want to share?
So we just published the estimates of obesity and underweight for all the countries in the world earlier this year, and we have a recent paper coming out a few days ago looking at the associations between BMI and weight to height ratio. So central and central abdominal obesity, how they are related to hypertension. That's of huge interest for the clinical audience. And we are also in the process of updating our previous estimates of hypertension, diabetes, and lipids levels for all the countries in the world. Hopefully it will come out later this year and the next year. So watch this.
Excellent. And I mean, the WHF report, when is coming?
Next year again, May next year, and has to be a surprise, Pablo. The topic?
Yeah, let's keep
the surprise. So just be with us. But next May 2025, we will have the new report following the success of this year report on air pollution and cardiovascular health.
Okay, thank you again to everyone, and yeah, well, I'm sure we'll keep working together. Thank you.
Thank you very much.
Thank you.